Good afternoon. Thank you for joining us for your lunch hour in beautiful sunny Florida in this dark cavernous room. So my task is to take you through the evolving clinical landscape for UC, and in discussions with Bruce and Bill, what we thought we'd do is try to provide you with practical information based on evidence to make selections for individualizing your therapy for your patients. So we've heard a tremendous amount at this meeting, and perhaps very appropriately, about novel agents, biological therapies, therapeutic drug monitoring. I'm going to take us back a few steps and remind us of some of our foundational therapies and what we know about them, specifically in ulcerative colitis. So, of course, our current medications for UC don't only include all the wonderful novel mechanisms you've just heard about and the biologics we spent a lot of time speaking about this morning, but have included the 5 ASA therapies for mild to moderate ulcerative colitis, corticosteroids, both in formulations that are systemically active, more topical or organ selective or specific, and topical from a rectal suppository and enema and foam point of view. Our immunomodulators or immunosuppressant strategies, and then the available FDA-approved biological therapies. The novel therapies, Bruce has done an expert job in reviewing for you, and we're enthusiastic about several of these. And in my presentation, I'm going to bring you up to date, as he mentioned to you, on Tofacitinib towards the end, just because those clinical trials are completed and we're waiting for regulatory review. Now, as much as Bruce presented what we might call the glass being half full with all of our new mechanisms and exciting new options, I might strategize in a different way and tell you that there are some gaps in our care and the glass is still partially empty. We don't know the cause and we don't have a medical cure for UC. There are lots of clinical and evolving epidemiologic observations and associations and many theories. I always ask a new patient what they think is the reason they have ulcerative colitis, and I hear many. Often it's diet or stress from their perspective, but we know it's more complex than that. And we also, of course, recognize there's a large non-response rate primarily and a large secondary loss of response to many of our therapies. In addition, there's fear of adverse events by patients and clinicians. Just a quick survey on the internet, or if you're following any of the Twitter feeds, you can see what patients say about their therapies and their concerns, which some of which are certainly appropriate and others may be exaggerated. We know that surgery, while it provides a very appropriate option for many patients who need it, still has its downsides. And there is ongoing confusion between us and our patients, or at least a lack of communication, which is inherent in many things in medicine, but perhaps more so in some of these types of diseases as well. Now, we also recognize that there's a consequence to be paid, not just for Crohn's that's untreated or insufficiently treated or diagnosed late, but we believe that it occurs as well in ulcerative colitis. And you can define progression of ulcerative colitis as proximal extension of disease when it's distally extent in the beginning, stricturing over time in some patients, certainly pseudopolyposis. We've come to appreciate that many patients develop a dysmotility or perhaps some impaired permeability related to their chronic inflammation. Anorectal dysfunction has been described, and of course we fear neoplasia as a consequence of longstanding inflammation. When you look at our available therapies, this is representative of the 2 pivotal trials related to the MMX mesalamine. You can appreciate that while the drugs were better than placebo, there's still lots of patients who did not respond. And that's the gap in care that we describe. In addition, this occurs with our biological therapies. Of course, you appreciate this. Certainly in the limits of design of clinical trials, there were many patients who didn't respond. Whether you look in the upper 2 graphs here of Infliximab pivotal trials for clinical response and remission, or down below for adalimumab response and remission and golimumab, there's lots of room for improvement in terms of primary response. And we've certainly come to appreciate that much of this has to do with patient selection, pharmacokinetics, and probably disease mechanisms that we need to understand better. So if you want to start thinking about individualizing your care for your patients rather than just working through a step-up strategy, you should first understand a bit more about what the predictors are for a patient not responding well. You may not recall, or you may know already, but be equally surprised by it, is that our standard severity scale, the True Love and Wits modified scoring system for disease severity, or as Corey Siegel taught us yesterday, disease activity, does not include endoscopic severity. And of course, we all recognize that that's an important marker of severity of ulcerative colitis, and it is associated with subsequent need for surgery in many patients. So certainly the patient with severe ulcerations is a patient who you're going to be especially worried about for a variety of different reasons. We also know there are many other predictors of poor response or colectomy. Most of them are markers of systemically active inflammation or a more severely sick colon. The one I'll focus on for 1 minute will be the low serum albumin, which was one of the first lessons I learned about managing ulcerative colitis, and the prognostic value of an albumin. Now, why is low albumin associated with poor prognosis in ulcerative colitis? Well, it may be as simple as malnourishment in the patient who's developed food phobia and is not taking in adequate PO. It's uncommon that it's due to true synthetic dysfunction. That's not something we see in our ulcerative colitis population very often. But more frequently described recently, but an old concept, is the loss of protein in the bowel, a leaky bowel or a protein-losing colopathy. And I would suggest, and others have proposed, that this is a definite marker of a patient who is going to be more difficult to treat and more difficult to use protein-based therapies to manage. So understanding this is certainly part of understanding how to individualize treatment for the patients with more severe ulcerative colitis. Now, despite all of what I've just told you, depending on whose studies you look at, there's some nice data that look at the incidence of surgery for ulcerative colitis. And if you just look down the line here, whether you're looking at the midpoint year of the study before 1990, all the way through the more recent data, the likelihood of having surgery within a year of diagnosis of ulcerative colitis appears to be going down. Now, that may represent improvements in medical therapy or delays of surgery that would ultimately be needed because we're working through more options. It may also represent that some of the people being more diagnosed with ulcerative colitis in the modern era have a different version of ulcerative colitis. Maybe those older patients who have a milder disease phenotype are less likely to need surgery. That may intentionally be the case. But nonetheless, we have made some progress, and it's important to keep that in mind. Now, just getting back to the communication issue, I'll just remind you that patients think being diagnosed with ulcerative colitis means living with symptoms. They don't understand necessarily what remission is, or even if they do, they don't necessarily appreciate that they should live with remission, or they feel like they can't get there. So whether it's learned helplessness, normalization of symptoms, or a fear of calling you because of fear of the next therapy you're recommending, many patients live with active disease, which definitely affects their quality of life. So having set all that up, let me take you through a few therapies and give you some thoughts. Starting with mesalamine and understanding more about what we know regarding mesalamine use in mild to moderate ulcerative colitis. For a long time, we talked really about a dose-response curve for mesalamine. And the data to truly support dose response were actually much less than you anticipate. And what we've come to appreciate is that not everybody needs the highest dose of mesalamine you can give them. And in fact, when the delayed release mesalamine formulation of 800 milligrams was developed, and they performed a comparative study against the 400 milligram tablets and 2.4 versus 4.8 grams of dosing, you may not recall or know that actually there was not a difference in mild to moderate UC between those two dosing regimens. If you separated them out and looked at the moderate patients, there was a slight benefit to the higher dose. And you'll be interested to know, looking at the yellow bars there, that the patients with milder UC who got higher doses of mesalamine, at least in this formulation, actually fared a little bit worse numerically, suggesting maybe they had more side effects from the drug than benefit. At least that's a theory. Now, a subsequent non-inferiority trial was performed looking at the 4.8 versus 2.4 gram formulations with the 400 versus 800 milligram preparations, and you can see there was not a difference. So one of the messages for you today is just to remind you about what we've come to appreciate with 5-ASA. Very important drug when we need it, but the old discussion about 2.4 versus 4.8 is not always the case for many patients, and I would encourage you to be moving on to other therapies quickly when patients aren't responding as well. Now, there's another message that's come out more recently, which has to do with understanding the value of mucosal healing. At least that's the way I've interpreted the results from this trial. This was a trial where patients in an open label fashion were induced with 4.8 grams of mesalamine MMX. And after induction of clinical remission, they had a scheduled reduction in dose to 2.4 grams. So trying to answer the question we've always talked about, which was dose reduction over time. And what you're seeing here across each of those different three components of the graph are the Mayo scores. And what they found, and what we found in this analysis, was that patients who achieved endoscopic improvement or endoscopic healing could safely have dose reduction over time. So it lent some credible evidence, or at least more support, to the idea of mucosal healing being a deeper or more stable level of remission. So another message for you about your 5-ASA use, and whether you have patients who are going to be non-adherent or you're trying to get to a goal of management, mucosal healing matters, and you can think of it in many ways. And in this particular trial, I think it supported the idea that your patient who's going to be non-adherent, or you who choose to reduce the dose over time, may have some benefit if you know that they're healed. And we could maybe talk about that more later. Now moving on, another concept in ulcerative colitis that has evolved is the idea of trying to use non-systemic steroids before you use systemically active corticosteroids. This is the results of the US trial, the Budesonide MMX at doses of 9 milligrams, 6 milligrams, and a comparator of 5-ASA 2.4 grams compared to placebo. And what you can appreciate here, and the reason the drug was labeled for 9 milligrams, was the 9 milligram dose was superior compared to placebo statistically, and this offered a new option for mild to moderate UC. Now I'm guessing many of you in the audience have had some experience with it, and I'm also guessing that most of you have used it after you've given the patient 5-ASA. Well, that wasn't the way this initial study was designed, so a subsequent study actually looked specifically at patients who were failing or resistant to 5-ASA, who then got the Budesonide MMX formulation at 9 milligrams. And although it did not seem to be better than placebo at achieving clinical remission, it did achieve endoscopic remission and histologic healing strongly statistically better than placebo. So again, we have this problem of interpreting symptoms, but when we look at more objective data, this had some benefit. Now in clinical practice, I find that this drug is really for the mild patient or the mild to moderate patient, but the real moderate patient I don't think responds as well to this therapy, and I would consider moving through it. But if you're going to use it early. Don't start with pred and then go to this. We learned from the Crohn studies that prednisone exposure early leads to the risks of prednisone, or at least bone loss early, and you don't have the benefit of a non-systemic steroid. We've heard people mention this study a couple times. This was patterned after the SONIC trial in Crohn's disease. The UC Success trial was a comparative effectiveness trial that looked at monotherapy with azathioprine or infliximab, or the two drugs together, in immuno and biologically naive moderate to severe UC. The primary endpoint of steroid-free remission at week 16 demonstrated that combination therapy was better than either therapy alone. Now, different than SONIC, I'll point out to you that in Success, the monotherapy arm with infliximab was not superior to azathioprine. It has the same caveat of limitations from the SONIC trial, in that there was no dose optimization of azathioprine or of infliximab here. But the message here was that there was benefit to this combination approach, probably due to higher trough levels of infliximab due to the combo use. But that's another message to think about when you treat your patients with UC. Remember combination therapy. And we made reference to this during one of our discussions this morning. This is a European trial of patients in the hospital who were IV steroid resistant after several days. They were randomized to cyclosporine or to infliximab to try and answer the question which drug might be better. And at the primary endpoint of 30-day colectomy, the drugs were similar in efficacy and similar in safety. So if you're comfortable with infliximab, this is where we've talked about stacking the dosing, or appreciate the problem with getting patients to therapeutic levels. If you're more comfortable or understand how to use cyclosporine, I would challenge you to think that maybe this is a therapy for the right patients, and I'm not saying for many patients, but for specific patients as an option that's a non-biologic, a non-protein-based therapy as an induction strategy. And that's, of course, because we've learned that you leak protein and you leak drug. And this nice study from Amsterdam demonstrated that you lose infliximab in your stool, and the amount of infliximab in the stool correlated to elevation of CRP. In other words, patients with ongoing disease activity. So this is an important consideration. If you have a patient admitted with bad UC who has a low albumin, you should be thinking carefully about whether your protein-based therapy is going to work. At a minimum, many of my colleagues have said you start with 10 milligrams per kilogram of Infliximab. I would tell you in a younger patient at the U of C, we would be considering cyclosporine and then transitioning them to maintenance therapy with other agents. Now, a better way to know all this might be to start looking at therapeutic drug monitoring, so you're actually making informed decisions. These are data that were extracted from the pivotal trials for Infliximab in outpatients with moderate to severe UC. And what I want to point out to you is that when you looked at the trough level of Infliximab at week 8, so basically after you've started loading the patients, you could predict the likelihood of remaining in remission at week 30 and certainly by week 54. In other words, early dose adjustment based on a post-loading trough level or drug level can gauge dose escalation for subsequent stability out to a year. So why wait for the patient to lose response to know that you should be doing something? I think the next step for therapeutic drug monitoring should really be this type of post-loading measurement and adjustment, and I think that's where the field is going. Bruce did a nice job talking about the mechanism of anti-integrin therapies. I'm going to remind you about the pivotal trial results of the Gemini 1 study, which achieved all of its primary and secondary endpoints: clinical remission, durable clinical response, mucosal healing, durable clinical remission, and corticosteroid-free remission. A really solid trial result, as you can imagine. And so what we've come to appreciate is that this is a very good drug for ulcerative colitis, and what we've further appreciated about it is that it's a very safe therapy. So positioning this drug in the right patients is an important consideration for us. Now, we've also come to realize that you might have a better response if this drug is positioned before anti-TNF loss of response or failure to respond. When you looked at a subset analysis post hoc of whether patients had failed TNF before they received Vedolizumab or whether they were TNF naive, you can appreciate the TNF naive patients did somewhat better, and that would be supportive of the patients who may be less sick overall, or maybe it's just a difference in mechanism response. Nonetheless, this is an important message when you're thinking about using a therapy like this. If we can position it earlier, we're going to have a more likelihood of response. Very important message. And the safety now has been summarized in a recent publication in Gut, which was the integrated safety data from 6 studies with up to 5 years of treatment. So for anyone who's still nervous about PML, it does not happen with this therapy. Statistically, it would have happened multiple times by now, and we understand from the mechanism and the clinical follow-up safety data that that just is not the case. And you can appreciate that some of the other predictors of safety outcomes were what we've seen before: steroid exposure, narcotics, other confounders. So very important to understand this remains a safe therapy. Now, one of the questions that comes up clinically is, what do you do if you're giving people the standard dosing of Vedolizumab and they don't respond? Well, you can look back to that Gemini 1 study and see that the patients who didn't respond initially, who were then allowed to receive every 4-week Vedolizumab, did have some benefit. Not all, but some. And therefore, within 3 months of monthly therapy, you should be able to see whether that patient is going to be picked up. It would be nice if we knew a little bit more about how to predict that. And in fact, now we have some data related to Vedolizumab drug levels. So this isn't quite reached a full understanding, but as I mentioned earlier today, if you were there are a couple labs that offer commercially available Vedolizumab levels. And we know, just like we saw with anti-TNF, the patients with high CRP, low albumin, and those who are heavier are associated with lower Vedolizumab drug levels, which equates to lower likelihood of response, greater likelihood of loss of response. So soon we can start using these levels the same way we think about anti-TNF, at least in terms of understanding primary non-response, or when we might want to go to dose escalation when possible. So who should you treat with Vedo? Getting back to this personalized care concept. Well, I think that there are some different patients to consider. Certainly patients unresponsive or intolerant to conventional therapies and anti-TNF, but I'll remind you that the label for Vedolizumab does not require and didn't state that they had to fail TNF before they get it. In addition, I think it's a reasonable option in patients with unusual or other immune conditions, like the post-transplant IBD activation that we've seen. They're already on immune suppression for their transplanted organ. maybe this is the right drug that's more organ selective and safe for them to consider. And then we've talked about, is this the right drug for the older patient who has a higher risk of infectious complications? Maybe we should be using it before systemic therapies in general, and maybe we should be combining it or using transitional care from calcineurin inhibitors or other novel mechanisms we just heard from Bruce as a transition to this drug as a maintenance therapy. So there are many different options for us to consider going forward. Bruce introduced to you Tofacitinib, and we added it to my presentation since the drug has completed its phase 3 trials now, and the results were encouraging, and we're expecting this to be reviewed positively, but hasn't been made available yet. But nonetheless, looking at patients with moderate to severe UC, the induction dosing of Tofacitinib 10 milligrams twice daily, which is twice the currently available dose for rheumatoid arthritis in the U.S., was statistically superior in 2 clinical trials compared to placebo. Secondary endpoint of mucosal healing was also met. Now, similar to the message I gave you about Vedo, patients who had prior anti-TNF exposure did worse, were less likely to respond to Tofa than those who were TNF naive. Again, suggesting that when you're thinking about your individual patient and you're trying to understand how to make decisions, as we evolve our algorithms and as you are able to make decisions, it's important to take that into consideration. Now, I have to include this as well because this multi-donor FMT study, which was performed in Australia, has demonstrated some efficacy for UC, and it comes up all the time, so I wanted to share these data with you. This was a multi-center randomized placebo. They gave placebo fecal transplants, including odor. Not sure how they did that part. And in order to do this, they had a single infusion by colonoscopy followed by enemas 5 days a week for 8 weeks. And you can see the primary results in the table on the left there. It achieved statistically significant clinical remission and clinical response. It did not achieve endoscopic remission, but did have endoscopic response. And the primary outcome of clinical remission plus endoscopic response, response or remission, one could argue is better than some of our biological therapies. The problem is that it's a pretty intensive treatment. I think we have to understand a bit more, and I know that the investigators are still doing some subset analyses and careful microbiome analyses to better understand this. So at the current time, this is not a recommended therapy, even though in theory it is very available. So I'll summarize and tell you that I think that as much as we've talked about a lot of our new therapies, our older therapies are still appropriate, but you need to know the data and you need to understand when to use them and when to move through them. We're certainly moving towards less systemic therapy, these steroids that are more organ selective and have rapid clearance, and of course our biological therapies that have mechanisms that are more organ selective. We have recognized the value of combined immunomodulators with anti-TNF, or at least with Infliximab, but we recognize that that's more likely pharmacokinetic than individual mechanisms. So TDM and certainly early therapeutic drug monitoring after loading, I think is going to become standard of care. We know Vedo is effective, and now we certainly know that it's safe over longer term follow-up. And the new options of FMT and Tofa are not quite available yet, but you can use Tofa off-label. As you've seen the data today, you can start thinking about that. Thank you very much.